So system by system, again, skipping the GI into the GU system. So a lot of this should feel like we've seen this before. We know what's going on with this. You should feel pretty comfortable with some of this stuff. A few different things that we will talk about. The disclaimer that I will give here is that pediatric nephrology is incredibly complicated. It's pretty nuanced and it is pretty rare. So do with that what you will for study times. It's a small section of pants. It's very hard to test on. So do with that what you will when you're studying. Okay, so if we're talking and we're starting to talk about urinary tract infections, that's a big blanket term. So anything in that urinary tract is going to be classified as a UTI. So you could just have cystitis alone, it's a UTI. You could have cystitis and pyelonephritis, it's a UTI. You could just have pyelonephritis, that is also a UTI. So UTI is going to be that big umbrella terms. When we're thinking outpatient, not critical, pretty healthy, stable patient, cystitis, when your filters are involved, the thing that is filtering your entire blood process, that's going to be when you have pyelo. So pyelo is a much more serious, and for children, that is going to be a much more serious. So when you think back to, you guys have probably seen this case several times in ClinCore, the pyelonephritis case, where it's pretty uncomplicated in the adult female world. If your filters as a child are involved, that's a much more serious case. Their stroke volume is higher, their heart rate is higher, they seed other places more quickly. So pyelonephritis in each child is something that we usually take a moment's pause before we're going to just treat that outpatient, because there's usually something else going on with that. Thinking about what your most common bacteria, often from that colon, so E. coli, from the colons, your most common. And then all your other bugs that have some differences in pH. So a lot of these bugs, particularly like Proteus, is pretty sticky. Some of the Klebsiella bugs, Enterococcus, Pseudomonas, they do different things than with pH than your typical bugs that we've been talking about over and over. Your heat bugs, your skin bugs. So your UTI bugs are a little bit different when you see some of those things. So what I want you to always cover for, no matter what you do, is covering for E. coli. When in doubt, cover for E. coli, and you're going to be a pretty safe place to start with that. Big differences. If you're under a year old, you do not know, nor can you prove as a provider, that this child has normal anatomy. So it's not just necessarily a run-of-the-mill all the time. You're worried if they're under a year and truly getting UTIs that something with their anatomy is off. That shouldn't be happening. The most common of that is going to be that you have vesicoureal reflux, or VUR, call it that for the rest of the time, meaning you have retrograde flow. Urine should always be going anterograde, forward and out. Retrograde flow, something with reflux is happening there. Mentioned it a couple times, uncircumcised males, less than 1. So it's particularly those two things put together. It's not uncircumcised males who are older, and it's not younger than 1 who are circumcised. So you have to have both. Uncircumcised and under 1, you're increased risk for UTIs. And then after that, outside of that, so you're not 1 anymore, you're not under 1, so less likely anatomy. You've proven over a year of life that you have pretty normal anatomy, and you're not a uncircumcised male, then most of the time this is going to be girls. Why?
Smaller
You're in
urethra.
a diaper, you have a short urethra, correct. Very, very close to the anus. So anytime you have a transition, that's when you're going to see problems with UTIs. So infancy, why infancy?
Diapers.
Diagnosis because of your anatomy issues. So infancy has issues because they have anatomy issues. Toilet training, it's a transition. Some constipation going on. Hygiene, wiping, all kinds of times with transition. And then onset of sexual activity in teenagers. So anytime you have this big transition, I was born, I'm starting to potty train, and I'm starting to have sex. Those times are when you typically see UTIs in children. This is kind of restating a lot of that. So we've already said, okay, what are your risk factors? You said, yep, we're female, just put you at a higher risk factor based on your anatomy. Uncircumcised male has that anatomical preference. EUR, toilet training, so all of those we've talked about. The other ones I want you to have constipation. So if you have chronic constipation, your gut is so distended with poop that it can block your outflow tract. So that can be a significant factor in kids. So if you have a child who's getting recurrent UTIs, your very first thing you will do is clean them out completely. So we'll catch that on that GI lecture on Monday. Anatomical abnormalities. So when we say that, probably under one. Other things to consider though, or do you have a labial adhesion? So typically you see that in pre-pubertal girls. Makes sense? They don't have that estrogen that keeps the labia apart. And those labial adhesions, they can adhere together and it almost makes a little pocket where stagnant urine can go and sit. So it makes it more likely that you're going to have a cystitis from that. Certainly a neurogenic or a neuropathic bladder, where you're more likely to have urine stasis, is going to be a problem. And then we already mentioned sexual activity. So those ones should feel very familiar, or at least kind of building on some of those earlier slides. Okay, cystitis, just bladder, no renal. And this is, for the most part, going to be the same things that you are going to see in big kids, in the big humans. So they're going to come in and say, it hurts when I urinate, I have to go a lot, so they have the frequency, not much volume, potentially an odor, some of those exact same things you're going to see. The difference with kids, and we talked about this in way back in block 1, sometimes they have 0 symptoms and they're only crying. So what was the one lab that we did and the one entity that we did where urinary tract infection was the thing that we were thinking about? See it back there. What was it? Colic. Yeah, so if you had kids with colic, they were just crying. The one thing that you would look for was that UTI. So you were getting a UA on those kids. Because oftentimes, that is the only symptom in those babies. So for colic, thinking, is this a uncomplicated cystitis? Then I'm thinking, is it actually uncomplicated? Is something wrong with their anatomy? For pyelo now you've got your filters involved. So what I worry about in children with pyelo, why they're getting these infections, they're at a higher risk for having renal scarring. So the glomeruli can scar much easier than the adult population. So one bout of pyelonephritis is a much bigger deal than, let's say, the adult world. Because it is in those filters and this whole system is involved, you see systemic symptoms. So typically these kids are going to come in with a lot more nausea, vomiting, have a lot of trouble holding down fluids. They will often come in then particularly with fevers as well. So if you get a kid that's coming in, you don't have a good explanation for the nausea, vomiting, potentially even diarrhea, and the fevers, and they're just not good here, kind of in the whole midsection, a lot of times they have trouble distinguishing where things hurt. Pyelonephritis is pretty high on my differential. In a newborn, the newborn presents with a very specificity. They have high jaundice or high hyperbilirubinemia early. So those kids that come in, I'm always thinking, is there an E. coli sepsis from a pyelonephritis pretty early? So this slide, I need you to take away 3 things from this. Number 1, in a kid, you are never going to separate a UA and a urine culture. For the rest of your time together, and being a PA, I need you to marry those 2 up in children. There are times in the adult world where you can just get a UA, and you can make a lot of diagnostic decisions based on just the UA. For the rest of your time in medicine, please do not ever unpair the UA and the urine culture for a kid. They go together, much like TSH and free T4. Those are just going to marry up in kids. So that's thing 1. Why do we do that? Well, why do children wear diapers?
So they don't pee everywhere.
So they don't pee everywhere. Why would they pee everywhere?
Lost control, bladder control.
Because they have no control over the bladder. So when liquid hits the bladder, what happens?
Comes out.
They just pee it out, right? So that's what's happening with the UA. When you were checking an adult UA, you had urine that's been sitting there for a while. there is bacteria in there. It has had time to make its byproducts of LE and nitrates. That doesn't happen with children. That's why UA sometimes not as helpful. That's why you need the culture with it to see what's going on. Also, because they're not potty trained, how well is it going to be to explain a clean catch to a 9-month-old baby? 1,000,000% impossible. So the second point that I need you to take from this, always pair UA and urine culture together. 2, if you're under 2 or not potty trained, you have to do a catheter. It's a straight cath, but you have to do it. Otherwise, your sample is completely invalid. How many of you have worked in an ER clinic somewhere else where they do a bagged specimen like this on a child? How well do you think that this bagged specimen that has all the skin flora and everything on it is going to go for this child's UA? Can you interpret that at all? No, not particularly. So you are going to see in your career, people are going to do these, they'll call them bags, these perineal bags, and they'll say, well, can we just put the bag on the kid? You can. You won't get a specimen that you can interpret very well, but go for it. So that's my third thing. Bags, avoid at all costs, even in those older kids. If you can't do a clean catch, avoid the bag. So UA urine culture, always cath if they are not potty trained or under 2. And please, for the love of God, don't use bag at all costs. Those are my 3 takeaways. So if you do have just the UA, so sometimes you'll get called as a provider and said, we cathed and we only have a milliliter of urine. What do you want to do with that? You're the provider. Do you want the UA? Do you want the culture?
Culture?
Always pick the culture. I want that culture. That's going to help me later on. So I want that culture. But if you have enough urine and you are able to get the UA, a couple of things that you're going to interpret a little bit differently. If you even have the wisps of 10 WBCs, if this child's body, from the time that they were not potty trained, is able to get 10 WBCs in this urine, that's an indication that there's an active infection going on. So 10 WBCs is going to make that. Your LE and your nitrates, certainly if you have them, that's going to be pretty specific. So again, that's not super sensitive, especially in the adult world. A lot of people are going to have those, doesn't make them particularly sensitive, but very specific. So if you, especially which one, LE or nitrates?
LE?
Which one, if you see that, you're more like, that is a UTI.
Nitrates.
Correct. So same for a kid. If you get a UA back and there are nitrites, that is a UA, or that is a UTI. If you get those epithelial cells, so you're more likely to get a bunch of epithelial cells from a bag or from a cath?
Bag.
Bag. So if you get a bunch of these cells, even from a cath sample, you really worry about your validity and is the sample contaminated. So a thing to consider when you are interpreting this. Your urine culture then is your gold standard. You must have these for confirmatory. So if you are an infant or a young child, I usually classify young child as toddler and below. So we are cathing this child, very, very young child who is potty trained. So sometimes those 2 to 3-year-olds, I'll still use that, and then certainly below 1. If you have 50,000, and what does CFU stand for? Colony forming units. If you have that, that's considered a slam dunk. If you have older children, and older meaning they are fully potty trained, they can wipe themselves, and you are trusting that their hygiene is intact, it's going to be more like the typical standard that you're aware of. And then if you get a suprapubic tap between that 1,000 and 50,000, that is also valid. I, in 14 years, have never seen a suprapubic tap for a child with a run-of-the-mill UTI. So if you see that, call me, let me know, because I want to know what was around that clinical scenario, and we will chat. So for our purposes, focus on, I need the culture, and I need it to be more than 50,000 for a single pathogen, unless something else is going on with that. And now I'm going to do these oral antibiotics. So, as with pneumonias, as with a lot of the things that we've been talking about, pertussis, anything where I'm worried that it's going to go the other way pretty quickly, about 6 months is your cutoff. So if you have a child who is under the age of 6 months and who has anything looking funny on those vital signs or just clinical impression, I really think about admitting those kids. But if you're over the age of 6 months, you're not ill appearing, you have this positive UA, you're like, that's a urinary tract infection, we can't do oral antibiotics. If you are toxic appearing, so that one should be obvious. This child looks sick. Or this child is incredibly dehydrated, so maybe they don't look that sick, but they've lost so much fluids from the vomiting or diarrhea. Or if they can't tolerate PO, so that should make sense. If you're like, here's your antibiotic, and they can't take the antibiotic, that's another indication to admit them for IV antibiotics. Kind of a long time for those neonates. If you're under a month, you've bought yourself 14 days on IV antibiotics. So not an insignificant amount of time. And typically we do about 10 days for most or older children. 7, we're starting to move that direction, so kind of 7 to 10 days. This should be one, because it is a bacterial infection most of the time, that if they're really not better in a day or 2, go back to the drawing board. I need another sample. I need to call the lab. Do we have the antibiogram? Is there resistance? Because they should be a lot better by tomorrow. So let's say it's today. You're seeing someone in the clinic right now at, what time is it? 11 o'clock. And you get that urine culture, right? You know the weekend is coming. I really think twice about that if they're not better by this time tomorrow. They should be significantly better. So if it's going into a weekend, this might even be a patient might say, can you come back and give another sample so that we have 2 going into a weekend? Something to think about when you are in practice. Weekends sometimes really matter. Susceptibilities, your culture results, always covering for E. coli. So our go-to, so the one that I want you guys to be familiar with, is your 3rd generation cephalosporin, your septimere. We use that one also for ear infections as kind of 3rd line. What was your 1st line for an ear infection? Moxicillin, high dose or low dose? High dose. What was your 2nd line for an ear infection? Augmentin, amoxiclav, correct. And then your 3rd line? Septimere. What do you have to tell the families about septimere? It's a really weird side effect. What color does it turn your poop? Kind of orange-red. Sedona red. Clay color red. So you can see how that would be a really concerning finding if the parents come in for a urinary tract infection and now they open the diaper and it looks like there's blood. So please warn your families that septimere is going to make the poop be some different colors. You can use amoxiclav. I don't love doing that. A lot of resistance there. Trimethoprim. You can use, again, don't love it. Nitrofurantoin. I love that medication, and I can't use it in babies. Why, you ask? Well, it's because it concentrates in the bladder. And that's the one thing we said babies can't do, is concentrate their urine, because they're not potty trained. So this would be your just about worst choice for a UTI, would be a nitrofurantoin or a macrobid in a baby. So pick just about anything else. So your go-to med for women with an uncomplicated cystitis, because it works so concentrated in the urine, is the worst thing you could pick for a baby. Okay, so this is a really good example of how it makes sense, and you're like, this is such a good drug for an adult, not the baby. Okay, so that's a particular one there. If you need to do IV antibiotics, so you're admitting them under 6 months, a pyelonephritis that's going to use IV drugs, you're going to use that bioequivalent of that 3rd generation cephalosporin with ceftriaxone. So your go-to for that. Could we use ceftriaxone for ear infections too?
Yes.
Yes. Yes, you can. In the clinic, how would you give that?
Orally?
Yeah, I am. Yep, you're going to do IV in the clinic, right? Unless you're going to hang out and sleep in the clinic all night. And night and day. Okay, so prevention then. So this is a big one for kids particularly. You'll see this in adults, but most adults for the most part got this down in life, right? Yay, life. But good hygiene, so a lot of times we'll just talking to parents and making sure that parents are aware to teach their children to wipe front to back, not back to front. Chronic constipation. When we get to that GI lecture, your first thing for abdominal pain in kids is going to be constipation. Your second, constipation. Third, constipation. Fourth, fifth, sixth, seventh, eighth, ninth, 99th thing is going to be constipation. So it makes sense that this is going to be a big factor for UTIs as well. Did you guys learn encoparesis in GI? So encoparesis is basically constipation on steroids. The stool is in there. It is so compacted. It is so hard at that point that you have a secondary diarrhea from that because the liquid stool is going around the hard stool walls. So we'll talk about that more later. If you have incontinence, that's going to be something that we want to look for and help manage if we can, and then BUR. So we're looking at BUR next. If you have that pyelonephritis, starting to think, of course, I'm going to have bacteremia. Why? It's in the kidneys. Your kidneys are filtering your blood, so of course that makes sense that you're going to have bacteria in your blood. Uncommon things we probably aren't going to see as often, but if you see a renal abscess, certainly something to think about. High relapse rate in these kiddos, usually pretty close, and things that we look for, new fevers. So a kid was doing a lot better, and now you suddenly have a new fever and you can't explain that. That's when you're saying, I need to get another sample, I need to repeat this evaluation. And certainly if it's recurrent, that's when I'm starting to do additional studies. So VCUG is going to be one of the things that we'll look for. About that in a second. This top bullet is very confusing. I get a lot of questions on this. I should probably figure out how to reword it. I don't have a great rewording, so if somebody else has one, let's work on that together. But the takeaway from this slide that I need you to get is that while you're potty training, you get a free UTI. That's basically how to think about it. If you're potty training, you're working on hygiene, you're working on when do I go, when do I not go, maybe there's some constipation, maybe there's some wetting of the pants. If you're potty training, you get a free UTI. I don't need to do a big workup. I don't need to do all kinds of other things. Potty training, free UTI. If it's outside of potty training, so you are either under a year, right, where you think, some anatomy is off somewhere, or you're older and you don't have an explanation for why, that's when I start doing some imaging, because that doesn't make sense then anymore. It makes sense when you're an infant, when you're potty training, and the onset of sexual activity. Outside of that, it doesn't make sense, and I want to make sure that you don't have something else going on. Okay? So after your first free one, if you're potty training, your go-to imaging is going to be your ultrasound of your renal and bladder. So I care much more about your renal ultrasound, but the bladder can be helpful too to make sure there's no obstruction and nothing with the junction going on. So that's first line. Second line, let's say either that's normal, you're still having symptoms, or that ultrasound is abnormal. In those scenarios, then I go into your voiding cystourethrogram. This is it a comfortable procedure or a not comfortable procedure? Not comfortable procedure. Did Major Passion talk about how they do this? Okay, so for a voiding cystourethrogram, please sedate the child. The child will be sedated because it is so uncomfortable, and you are basically pushing a dye retrograde into the bladder. That is where it should stay. It should just stay in the bladder. If it continues to retrograde and ascend up, that's when you are looking for some sort of BUR. Okay, so very, very uncomfortable for this patient, but it can also then show you all of your different anatomy throughout, because the dye will go wherever it can go. So it will show you if there is some sort of hydronephrosis or scarring or any kind of other abnormality. So very, very uncomfortable. So first thing, free UTI. You are potty trained. Second, renal bladder ultrasound. Third, if you need it, because the ultrasound's normal and you're still having it in problems, so you're worried about something deeper anatomically, or the VCUG was, or sorry, the renal ultrasound was abnormal, VCUG is next. Big takeaways. Which takes us to BUR. We already said it's retrograde flow. Did Dr. Evans talk about BUR a whole bunch? A little bit? Okay, so, or did you guys, have you just blocked out that whole block with Dr. Evans? We just blocked out Dr.
Right in the
Evans.
trash can.
There's PTSD from that, so we just blocked out from there. Okay. So this is one that is pretty highly correlated with a congenital defect. So you'll see this a lot of times on ultrasound. A mom is told she has a hydronephrosis, the kidneys are enlarged, there's extra fluid, something's up with the kidneys going on, often congenital. You will often see also where the ureter comes into the bladder, right at that junction point, you have some immaturity there. And so you get some retrograde flow potentially there, that as they get older, kind of the angle changes and stiffens up a little bit, so you don't have as much of a problems with that, but so it matures over time. But this can cause that retrograde flow, and we need to figure out how bad that is and how we're going to manage that. So certainly if there's an obstruction, which is part of the bladder ultrasound, if there's an obstruction and you have retrograde flow because of that, something that we want to look at as well. Just that picture of it should always go from the kidneys, through the collecting system, down the ureters, into the bladder, should not go back up. Right? We don't want that. We already talked about your VCUG. Please, it says you may need, your textbook says you may need to sedate the child, but give them something. Like, don't do that. That is just not, give them something. Okay, so the grades of this. So, grade 0, which is not a thing, but it would just be a negative VCUG, would be if you inject dye into the bladder and the dye doesn't leave the bladder. Right? That's normal. That should be what happens. That's normal. So it's negative. I kind of call it a grade 0, but that implies that there's VUR, so can't do that. But negative is it doesn't leave the bladder. Grade 1, it leaves the bladder, but it only goes up partially from the ureter, so you get some retrograde flow, but not a lot. Grade 2, it goes all the way up your ureter, but it's not causing any sort of dilation. Grade 3 is where your dilation happens, and that's really the pivotal change, is grade 3. So when you have some retrograde flow going all the way back to your kidneys and it's dilating the collecting system, that's when you start to see problems. Grade 4 is an exaggerated grade 3. You see much more dilation. And then grade 5 is where you see one of my favorite words, tortuosity. So the ureters are so dilated that you have some aberrant anatomy where the collecting ducts and the collecting system really is kind of out of sorts. The nice thing about this is that radiology is going to tell you how bad it is. Okay? If I look at these scans, I'm like, like I can tell some of them, because some of them are obvious, but if you're looking at this, that's really hard for me to say, is this a 3 versus a 4? I would have probably called this a 3, because I would have seen some dilation, but not a ton. So this is where our friends in radiology are very, very helpful, because if you know somewhat, I know that that's in the bladder, I see the contrast, I see it going up the ureter, I see it completely in the collecting duct, in the collecting system, but 3 versus 4, that's really difficult. So I'm not going to ask you to say, is this a 2, 3, 4? That is what radiology and our colleagues there are going to help us with. I want you to be aware of, oh my goodness, I have retrograde flow, and it's starting to dilate, meaning it's really not anterograde. It's really retrograde, and it's starting to cause problems when we're backing up significantly. So we need to take care of that anatomy. So grades 1 and 2 kind of says those are the ones where often they will resolve without some sort of surgical intervention. So if it's unilateral, if it's bilateral, if they're young, if they're old, they usually do okay because there's no dilation. That dilation is really our critical point. So grade 3 means it's all the way up the ureter, all the way into the kidney. Now you have some dilation, but these are our buts. If it's one-sided, much better, and if they're younger, much better. There's a lot more likely that they're going to outgrow that. So younger and one side, much better. So a grade 3 unilateral in a 6-month-old, way different than a grade 3 bilateral in a 6-year-old. Okay, does that make sense of how you're doing both of those? Once you get into the 4 and 5, significant dilation, significant tortuosity, a lot of anatomy involved in that. So that one is less likely to resolve on its own at all, and often medical and surgical intervention. So, who are we going to refer grade 5 to?
Pediatric urology?
Pediatric, who?
Urology?
Urology and nephrology. Correct. They need both medical and surgical management. Who are we going to refer a grade 2 to?
Pediatrician.
Pediatrician and nephrology. You just need medical management. Okay. So everybody, VUR, everybody, 1 through 5 needs nephrology. They all need medical management. There is a component of this that has to have medical management because the parenchyma of the kidney is involved. However, when you get up into that 3, 4, 5, that's when I start to think, ooh, I might need surgery involved. So it's nephrology and urology. That difference between nephrology and urology is coming back. We're going to see it on this test again too. So who are you referring this to? So for everybody, nephrology.
On the stethoscope.
For these ones, we do a couple of things. Part of the medical management looks like timed voiding. So if you've ever been around a child and all of a sudden in the middle of the day they're like, I have to pee, and you haven't realized they haven't peed in a while. These are ones that you have to say, nope, at very regular intervals we're making sure that we have anterograde flow. We're getting things out. Fecal elimination. We want these kids to be completely cleaned out. We don't want constipation to be on the table as part of this pathology at all. So we keep them very, very flowy. We want to increase fluid intake. Well, that seems counterintuitive, right? A little bit. But we want to make sure they have as much anterograde flow as possible. We don't want to give any of that retrograde flow a chance to go backwards and stay stagnant. So we want to be moving everything constantly forward and out. And then certainly if there's any UTIs, we're going to do a prompt and quick assessment. So we usually see that medical management do really well with grades 1 and 2, where you have that flow without the dilation. When you start saying, I need to also give microbial prophylaxis, I need to put this kid on an antibiotic every day because there's such high risk of getting a urinary tract infection, that's when you start looking at your higher grades, grades 4 and 5. Is typically who we're doing that for. They're symptomatic, they get UTIs easily and often, and having that prophylaxis can be very, very helpful. And then for the surgical management, when we talk about those high grades, we're usually talking 4 and 5. Occasionally we'll see that in a bilateral 3. But for what our purposes are, please associate that surgical management with 4 and 5. Few other kidney and renal abnormalities. So I told you at the front, very, very hard to test on these things because they look so different. So this is, again, study how you will, but take that how you will. When I'm looking at some of our polycystic kidney disease, whole bunch of different things. So we can see polycystin defects or fibrocystin defects. All of those are making up the structure of the kidney. When you have defects in either one of these, the kidney makes these giant cysts. Do you think that I care more about the dominant or the recessive type? The recessive type. Why? Because it affects kids. Correct. So the dominant type, while very concerned as a provider about all the patients, this one really, for the dominant side, you see it in a middle adulthood. So that would be something that any one of us might start to see. I'm starting to have cysts on my kidneys. And while I think each and every one of you are special and wonderful and unique unicorns, from a patient population, I care much more about the little kids. And so that is going to be where you typically see the autosomal recessive, getting it from the 2 parents. And you see this in early childhood. A lot of times you can see this on their prenatal ultrasounds. You'll see this with oligohydramnios. And so rather than having enough fluid to be able to swim in, their kidneys really functionally are not making any kind of fluid. So that is one of the things on a differential. If you're in women's health, they are looking at this ultrasound and they're like, man, these are low fluid levels. Immediately I'm starting to think, what is wrong with this baby in utero? Why aren't they making any fluid? What's wrong with the kidneys? When we say there are cysts on the kidneys, I don't mean just like little cysts. I mean like the cysts are so big that the kidneys have taken over the entire abdominal cavity. I'll take a couple of pictures here. So giant flank masses, and then if you had a UA, there's tons of protein, tons of blood. It's just not good. It just takes over the entire abdomen.
Whoa.
So this is a baby in the NICU. If you look at that, you're like, I don't know a lot, baby, but I know that that abdomen is way too big, and that is not normal. If you're looking below at that CT scan, the entire abdomen is full of kidney, right? But it's not just, oh, this is awesome giant kidney syndrome. This is the kidneys don't function because they are so enlarged with cysts. Oh, and they're taking up the entire abdomen. So they need to remove both of those kidneys. And often then the child ends up on a dialysis. So this is that same child with the polycystic kidney next to them. So you can see it literally was the size of that abdomen, and really functionally all you're seeing there are cysts. So a rare thing that we do see, but polycystic kidney, not great outcomes. If you're looking at renal hypoplasia, again, your medical terminology, so hypo meaning small, plasia meaning it was made really small. So sometimes there's some functionality to these kidneys, sometimes not so much. Sometimes unilateral, sometimes bilateral. So this is one, if it is a unilateral one, something that we will watch for most of the time, that second kidney to kind of make up for those differences. But sometimes we're a little bit more protective. So something to think about, if a kid comes with a renal hypoplasia unilaterally, and they're saying, I really want to do tackle football. Well, something a risk to consider. Are you okay with that one kidney being the sole source? Maybe, maybe not. Renal dysplasia. Well, that ain't normal. You're looking at that and you're trying to find any kind of normal glomeruli in there. Good luck. Okay, so there's different amounts of dysplasia. Certainly this can be small, large. Functionally, the difference between dysplasia and hypoplasia, dysplasia is not working at all. So it's not just small or large, it is not functional. So that does not look like a functional organ, and it's not. Other variants that we can see are a horseshoe kidney. So this kidney, it really didn't split into two sides, so it goes all the way around. So that retroperitoneal organ. Sometimes they have double collecting systems, so they'll have two ureters down into that one bladder. This is often an association with Turner syndrome. So way back, we said there was some growth restriction, there was some infertility issues, there was some lymphedema issues, there's also a horseshoe kidney. Remember what organ formed at the same time as the kidneys? Heard it. Yeah, ears. Ears are going to form at the same time. So something to think about. If you have a baby who has some ear abnormalities, or you know that the baby has Turner syndrome, maybe I'll go ahead and get that renal ultrasound just to see what's going on with that anatomy. And you guys look like you need a break, so why don't we take till 11:20 and then finish this one up. So, testicular torsion. What do you guys know about testicular torsion?
Bad.
It's bad.
Ultrasound it.
Good. You should ultrasound it, yes. Who do you need to call if there is a torsion?
An adult.
Urologist, yep. And in 20 minutes,
Right now.
Yesterday.
Right
Yeah,
now.
like it is an urgent one, as urgent and stat as you can do. And how long do you have to save the testicle?
8.
And not
12.
even that long in kids, about 6 hours. Okay. So what's typically happening? So most of the time it is an abnormality from the anatomy, where normally the testicles, I like this picture better, normally the testicles are oriented kind of in a vertical line. In this bell clapper deformity, the testicle has a horizontal lie, and that horizontal lie, when it's not kind of tacked down, allows it to spin on itself. It is more likely to get torged because of that. That torsion then cuts off the blood supply. That blood supply causes that local necrosis, and thus the testicle dies. So, a lot of times this will happen when there is sudden movement or sports. That's typically how I've seen it in the question stem. In real life, do you guys have an idea of the most common way that I've seen this? Not quite sitting down, but very close to that. Somebody's just sleeping. They wake up and they're like, I was just sleeping and this now happens. So that is the most common way in real life every single question I've seen about it for the boards. You're in a sports and suddenly they had this one right-sided unilateral or left-sided, either way pain. So watch out for that bell clapper deformity. What is the cremasteric reflex?
Stroke the thigh and
You stroke the thigh, and what is supposed to happen?
the testicle raises up
It rises. Why does it not happen here?
because it's tied up.
Yeah, it's already tores, often so tight that you could do that all day long. There's nowhere for it to go. Okay? The preem sign, what is that? Yeah, you lift the what? You have to lift this whole scrotum. You should have pain decrease if you are positive for what? Yep, epididymitis, or sometimes an orchitis as well. In this, that really doesn't do anything because it's still tores. Okay, so those two signs you are going to see at. Reminder how that torsion looks, and again, reminder of the appendix of the testes, because that is just one of the most common board questions as well. That torsion, you can see it can become a highly necrotic structure very, very quickly. There's a lot of blood supply to that torus area. So I would say I have a low threshold to even just take a visual peek if a young man, 10 and above, comes in and says that they're having abdominal pain. Taking a quick visual assessment to make sure you don't have that high riding testicle and that you don't have something that looks like that side on the left. Other things, so if you do have an orchitis or an epididymitis, you will see that it is relieved again. You guys nailed that one with that. You can see in the appendices of the testicle tores as well. I have never seen this, and the boards love this because they're trying to look at the difference between this blue dot, this teeny tiny little appendix of the scrotum that you treat with NSAIDs, or do I need to urgently call the surgeon to come in and save the testicle? So that's really what that presentation and why they're testing it so hard. In real life, I've never seen the blue dot, but it is one of the most common things that I see on the boards. So typically that appendices of the testicle is a little bit younger, kind of young school age, versus your testicular torsion is kind of middle school, early high school. Your epididymitis, orchitis, older teenagers, or then your older adult men. You could see an incarcerated inguinal hernia as well. Often every single board question I've ever seen about that, they give you bowel sounds. So if they tell you there are bowel sounds over that area, they're trying to tell you that's not the testicle. There's that blue dot sign with the appendices. If you ever see that, again, please call me. I've never seen that. It's kind of interesting. Your ultrasound, what kind of ultrasound do you need? Thank you, a Doppler. So you must see, is there blood flow to see that? And then, like you said, urgent, I'm calling yesterday to urology. This is one also, if I really think that there is even the maybe, possibly, I call urology even before I have the ultrasound. I just want to give you a heads up, there's somebody here with a concerning exam, getting the ultrasound with Doppler right now, but you might want to come see. Typically very, very painful, so you can see this in little babies as well. Sometimes birth can do this as they're coming out and have that rotation. So if you have that one-sided unilateral red testicle, and it's very, very painful to the infant, something you see, versus your inguinal hernia, again, not as painful, not as red, typically the has bowel sounds as well. Cryptorchidism. So, the testicles did not descend. I'm going to do this slide, I'm going to tell you a story. So, the journey, if you remember from Women's Health, the journey of the gonads down into where the ovaries sit for the females and then down into the testicles for the males. If you're premature, sometimes that journey didn't finish. So you have those testicles stuck somewhere along that pathway, oftentimes in the inguinal canal. A lot of, again, in those premature guys, can be bilateral often. Why do the testicles need to sit inside the scrotum? Temperature, okay, so that makes sense. The temperature is much cooler outside of the body. So if the temperature is higher and closer to the body, more likely that those cells are, number one, not going to function. You have infertility. But number two, that those cells are going to mutate and you end up with a testicular cancer. So for a couple of months, you can say, okay, maybe they'll finish the journey. Okay, we've done the 2-week, we've done the 4-week visit, we've done the 6-month visit. But after that, they're much less likely to make the journey. So if a child does not have descended testicles by the age of 6 months, do they need to go to nephrology or urology?
Urology.
Urology, because they're going to have to do an orchidopexy. So they basically pull those testicles all the way through and down into the scrotum and tack them down so that they stay outside of the body. What you're going to see is that providers, even the best meaning providers, will start cutting corners on exams. And they will not do full exams for every single visit. I would encourage you, if you are seeing a child, ever to do a full exam every year for their well exam and a sports physical. The reason I say this, it was maybe a year ago, a student sitting in your class, senior student, had a 10-year-old. This 10-year-old she had taken to every well visit throughout her entire time. I think she was guard or reserve, so she wasn't active duty. Same pediatrician. Pediatrician had not then looked at the child's genital area for several years, clearly. So she goes, it was time for the annual physical during peds. She takes the child to the pediatrician and they do an exam and clear him for sports. She says, oh, wait, you didn't do the general exam. Has he started puberty? He's 10 now. When do we expect puberty to start in boys? 9 to 14. So she asks a good question, appropriately clinical. Has he started puberty yet? The pediatrician goes to take a look, can't find the testicles. Can't find the testicles. Bilaterally undescended testicles that were never picked up on a 10-year-old, right? Who was getting regular care, whose mom was a senior in this program, okay? So not a dig at the mom, not a dig at anything. Why would you know if your 10-year-old's testicles were descended? That would be weird, right? But a dig at the providers, which we are in charge of our profession collectively, to make sure we're doing appropriate exams for the patients, okay? Because that should have gotten picked up at the 6-month well visit, okay? So, I would encourage you, if you have kids and they go to their well exams, to make sure that your provider does a full exam. If you are the provider and you're taking care of kids, they're there for a well visit or sports physical doing thorough exams, because you never know when it's going to be the 10-year-old that has that undescended testicles. Any of you missed this question on this test? Because that actually captivated all your attention. It's the first time. Little embryologic journey. If you remember that, I'm not going to ask you embryology. I just love it, so I put it in there. If you're on your rotations and you're trying to say, well, do the testicles, are they actually descended? I have a 2-weeker, a 2-monther, a 4-monther, and I can't quite find them. You will often hear your provider say, just try to milk the testicle. You're like, milk the testicle, huh? Not milk anything. Well, what they're saying is they're basically saying hold one hand with the scrotum at the scrotum and walk the other hand down the inguinal canal to see if you can find the testicle and get it into the scrotum, to see if it's just retractile or if you can actually get it in there or you can't find it. Okay. So my one beef with this picture is if you're doing that, for the love of God, wear gloves, right? That's a weird exam, like. But that's what milking the testicle is. So if you hear that, and we're not going to be practicing this today, so if any of you are bringing your kids and you're like, oh my God, we're doing general, we're not doing it. Just in general when you are practicing. This is what milking the testicle is. Other things you might see on exam would be a hydrocele, so you can see that fluid collection. The big thing about a hydrocele is what does it do with the light?
Illuminate.
Transilluminate. So if you hold the light up and it is just dark, do you have a hydrocele?
No.
No, you probably have an inguinal hernia. You have something else, but you don't have a hydrocele. So that transillumination is what you're going to see. If it communicates to the abdomen, that means it's communicating. If it's on its own little island, it's not communicating. Communicating, connected to the abdomen, not communicating on its island. If you have a communicating hydrocele, what does it look like in the morning versus at the end of the day? In the morning, it's non-existent. What does it look like at the end of the day?
Bigger.
Massive, okay? If you have a non-communicating, what does it look like in the morning?
The same.
What does it look like in the afternoon?
Same.
The same, correct. So that's a distinguishing factor that you would see on real life and then on a human seeing question. Most of the time, those non-communicating ones, those kind of little island hydroseals, they will spontaneously resolve. If they don't, at about a year mark, that's when I say we're going to have to go in and train these, because the island does not resolve. Your communicating ones, typically those ones are not going to self-resolve because they have that consistent communication. Oftentimes they go to urology a little bit earlier. Few penile abnormalities. So we're talking about hypospadias. We are talking about the ventral side of the penis. So there is a whole other entity. Well, let me back up. The gonads make their journey. So does the urethral meatus as part of embryology. The urethral meatus should go right to the tip of the glands. In this case, it doesn't. So if that gets off, it can go to a couple of places. Well, I'm not going to test you, it's not even on here, but if it goes to that dorsal side, it's an epispadias. We're going to talk about the more common type, which is the hypospadias. So it goes to the ventral side of the penile shaft, so it's not at the glands. If the urethral meatus is not at the tip of the glands, how does this typically present then?
Somewhere along the shaft.
Somewhere, yeah, it's on the shaft, but what are the parents saying, or what are the nurses saying right after birth? Baby's peeing, but what does the stream look like?
Going down?
Some other direction. Because the meatus is not at the tip of the penis. So if you are seeing this, the urine stream is some other direction, because the meatus is coming out not at the tip of the penis. That's how oftentimes it's going to present. Second way is that you're in the middle of a circumcision and you're like, oh my god, this is not normal anatomy. Oftentimes, if the meatus didn't migrate correctly, what I think is, well, did the testicles migrate correctly either? So I'm going to need to go and make sure that I have both testicles or get an ultrasound to see where they are. Also have an increased risk of hernia. One thing's off anatomically, I start to look for all the other anatomical things in this kiddo. If it is, another thing to consider on your differential is this a female? And this is actually too much androgens with a congenital adrenal hyperplasia. So something to think about. This one's going to need surgical correction. And so oftentimes the most common way that I saw this present was not necessarily the urine stream, but we'd be mid-circumcision, we would cut the foreskin, open it up, oh no, there's a hypospadias, stop the procedure. Because sometimes urology can use the extra skin to rebuild the glands. So, stop circumcision. I think this is interesting to be at the top. I'm not going to ask you about this, but the history nerd in me really thinks that it's interesting that over the last 100 years, the disease process has not changed one bit. The embryology has not changed one bit. And yet we've spent a whole lot of time renaming, reclassifying what types of hypospadias we have. I just think that is an interesting use of all of our time collectively as providers. But the big point of what we're looking at is when you're calling the urologists, we're now using the nomenclature to say, is this glandular? So is the meatus coming out somewhere, not at the tip of the glands, but somewhere on the glands? Is it the distal portion of the penis, or is it a proximal? So it's going to matter how they do their surgical management, is where along the shaft is the hypospadias. So being able to at least recognize it, ooh, that's not the tip of the shaft of the penis, and then being able to classify it to urology of where along there that is, and then not doing a circumcision. Big takeaways. Just for examples, it can be anywhere along that ventral shaft. So a glandular one more at the top, and start looking as it goes further and further down, more and more aberrant anatomy. When we think about circumcision in general, so things that we look at as an advantage, we said if you were uncircumcised male, you had that increased urinary tract infection risk in that first year of life. So it's going to decrease that risk. You're not going to have phimosis or paraphimosis if you don't have a foreskin. It's going to cause that. And it decreases penile cancer risk over time. If the foreskin itself can have cancerous cells, if it's not there, can't get cancer, so you see decreased risk of cancer. Some of your disadvantages, yes, there's always bleeding in infection, but really the biggest risk is going to be a poor cosmetic outcome. That's probably what I see the most common is somebody says, I don't like the way it looks. I don't like the way it came out. So both advantages and disadvantages, relatively small. So this is probably the one thing that we would say in peds, besides ear piercing, some clinics will do that, is a true elective procedure in kids. So this one's the boys, ear piercing for girls. Speaking of phimosis and paraphimosis, so every single baby, every single young man is born with physiologic phimosis, meaning that the foreskin should come over the top of the glands and it should stay there. That is normal. So when a family is like, well, do we need to pull the foreskin back and clean it? Actively do nothing. That's what I was going to do. I need you to actively do nothing. You don't touch it, don't mess with it, nothing. It's physiologic phimosis. What we worry about is when we get into the paraphimosis. And that's what we don't want to happen. You pull the foreskin back and then you can't get it back down. Now you have paraphimosis and they've got themselves circumcision. And let me tell you, there is nothing more painful to watch than adult active duty men with elective or non-elective circumcisions later in life. Okay? They are not happy and they end up with profiles for a long time. Enuresis. What is enuresis? Peeing. When shouldn't we pee? Yeah. So, urinary incontinence. When you have a child who should be potty trained. So, if you have a 6-month-old baby and you're like, this baby has enuresis, they absolutely do not have enuresis because they are not at a developmental stage where they could even achieve that outcome. Now, if you wet your pants right now, I would say that's absolutely enuresis, right? So they have to be developmentally able to achieve that to be considered having a true enuresis. We're going to classify it as 2 different ways. Are we talking about the daytime or the nighttime? And we're talking about primary or secondary. And that will really matter in clinic and then on a test question as well. So primary. This child has never been dry. Never been potty trained. Never been dry. Ever, ever, ever. Okay? Or never been dry at night. That's probably what you see more commonly. Is can't make it through the night. Can't ever do that. Secondary, the cutoff is 6 months. So you were dry, now you're not. There's 6 months. You were dry for at least 6 months. Things that I look at, is there some sort of disease? We're going to talk about that differential. Some sort of psychological distress. So things that I look at with that, are they being bullied? Is there a divorce, a deployment? Somebody new has moved in, an abuse situation. And then developmentally. So are you potty training right now and it's a difficult situation? Or do you have spina bifida and you have a neurogenic bladder? Things like that. So I look at the timing of it. So primary nocturnal, they've never been dry and it's just at night. So this one, when I say often a family history, what's your guess? If one parent wet the bed at night, what's the percentage that their child is going to wet the bed at night? I hear 50.
20.
20. 75. About 60. About 60% that if you have one parent who wet the bed, their child will. What if both parents wet the bed?
90.
Almost guaranteed. 95. 95%. So if you mate with a bedwetter, your child will probably be a bedwetter too if you were one. Like just statistically. But that's helpful to know because a lot of parents will come in very concerned about that and they'll be like, I wet the bed, he wet the bed, and you're like, well, that one is too. Right? But so that can be really helpful when you're thinking, or if you're the parent that didn't and the other parent did, and this one parent is freaking out, and you're like, 60% chance. It's okay.
Invest in waterproof sheets.
Secondary. So secondary, they were dry for 6 months and now they're suddenly not. And it's now during the day and or at night. Those are the most likely to have something actually wrong. Okay? You were dry, something changed, now you're not. That one worries me. The things that I worry about, are you infected? Did you have a brain lesion and now you have something wrong with your ADH and now you have DI? More likely, are you constipated? It's the common one. But the one that I don't want you to miss, the is how I've seen it present in young kids, is this is how they present with polyuria, and this is new onset type 1 diabetes. They were dry, now they're not. Why are they not dry? It's because they have so much urine and so much glucose. So what are we going to do then for these kids? Well, I want a urinalysis, and if I get a urinalysis, what do I get with it? Culture. They always marry up. Yep, urinalysis and culture. This is going to help. This is where UA actually does help, because if they had diabetes, what's going to be positive?
Glucose.
Your glucose, correct. If they have intraparenchymal renal disease, what's going to be positive likely? Blood. Yeah, they'll have blood and protein, right? So you have something going on with that. And then if they have a UTI, what's going to be positive? LE, nitrites, and WBC. How many?
10.
At least 10, yeah. So the UA can actually be really helpful for this one. When it's negative, and they're still having this, I do consider going ahead and getting a renal bladder ultrasound to make sure that that anatomy is okay. And certainly if there's the infection and it is new onset, then I start thinking maybe a BCH, much lower yield though for that. Okay, so let's walk through all four. So we said primary nocturnal, so you've never been dry and it's just at night. Probably your mom or dad or both had this, likely familial. Probably not going to find an underlying cause. Interesting, every year, about 15% of these kids will get better. So statistically, by waiting it out, they will outgrow this one. Secondary nocturnal. You used to be dry, now you're not, but it's just at night. Those are the kids when I start thinking about something with a sleep or something psychological. So does this kid have an OSA and he has these gigantic adenoids and tonsils that we need to get out, or a sleep disorder, or he's crashing after ADHD medications, something like that. It's just at night. Your primary day and night, those are the kids where I really think that there is something from birth going on. A spina bifida, neurogenic bladder, neurologic disorder, something else going on. And then again, the biggest one that I don't want you to miss, they were dry, now they're not daytime or nighttime, something organic's going on. So, the biggest one is diabetes. I cannot stress it. UTI or diabetes. First thing I want to do is clean every single one of these kids out. I don't care what type you have. When in doubt, clean it out. So you cannot go wrong with doing a bowel clean that we'll talk about on Monday. So underlying constipation is going to make everything worse, and urology will send them back to you if you have not done that. So very first thing, a UA urine culture, and clean them out. Again, reassurance, if they're those nighttime ones, they're going to get better. Limiting some fluid intake, having them go to the bathroom right before bed and right before the parents go to bed. And then certainly if there is another component with those secondary, getting them to the right specialist. With an enuresis alarm, does anyone know how this enuresis alarm works?
It goes off when you pee the bed, right?
It goes off when you pee the bed. When it say it goes off, what does that mean?
Very loud.
It can be. So it can be very loud. So it is either by noise or it can shake the bed. It can shake and wake. And there's a misconception, and I don't want you to have this misconception. So a lot of people will think, oh, it's just going to somehow sense when my kid needs to pee and it's going to wake them up, and then they'll go pee. And that's not how it works. It responds when the kid pees. So it responds to moisture, and then it will go off. And that's then the signal of, I have wet the bed, I need to wake up, and then take care of it. That also trains the brain to say, I associate the two together, and over time, that will create an association where they can wake up before they have to pee. But a lot of times, it's worse for everybody at first, because they're like, well, at least we were sleeping through the night and having to change the sheets in the morning. Now we're not sleeping through the night, and they're still wetting the bed. So a lot of families, that's where you see this high relapse rate, and you don't like it. Because there's a level of not understanding how it works. So it's not going to like sense that their kid needs to pee in 5 minutes before wake them up. So I just need that misunderstanding. Other things that we will sometimes do for these kids is medication therapy. So desmopressin is another name for what?
Vasopressin.
Yeah, vasopressin. And VD-AVP is what we're looking at here. So it's a stuff, antidiuretic hormone. It's basically what you give them so that they won't do this. I don't use this all the time. You don't want to mess with their HPA axis. This is what you use for sometimes. We're going to camp, we're having a sleepover, we're going to be out of town, sharing a bed, something like that, as opposed to using this every night. If you're using some of the other things, I would consult nephrology at that point. If you're starting to use other things that are messing with their fluid balance. And I think we did it with 1 minute to spare. Perfect. Thank you guys. We will